Hello, everyone, and thank you for joining us on the Leaders Supporting Leaders during COVID-19 Town Hall. Today is Tuesday, April 14th. My name is Carrie Lynn Vox, and I am the Senior Manager of Chapter and State Relations for AORN. All attendees have been muted. Your feedback is very important to us. During the Town Hall, please submit your questions or comments in the chat box below. We'll do our best to respond to all the questions in the last portion of the Town Hall this evening. Please review the outcomes for this webinar listed here. A link will also be provided after the meeting to view and download the webinar if you are not able to stay with us for the entire session. One contact hour will be for this session, and evaluation instructions will be sent tomorrow. I would now like to introduce Renee Bette, Vice President of Nursing for AORN. Renee?
Thank you, Carrie Lynn. Welcome, everyone, and thank you for joining the AORN Town Hall, Leaders Supporting Leaders. I'm really pleased to be your host for this meeting tonight. As you all well know, COVID-19 has very rapidly introduced a level of change in our work and home environment that we've never experienced. Elective surgery is canceled, operating rooms are closed or have transitioned into intensive care units. Periop nurses are redeployed or furloughed. Some hospitals are overwhelmed with COVID patient volume, and other surgery centers stand empty. The speed of the impact for this previously unknown virus has placed a tremendous demand on our profession, while it challenges us with human and supply resources to adequately respond. We have two nurse leaders with us who will share their COVID-19 experiences managing their teams, providing critical communications and training, and supporting the new reality in patient management in the OR and throughout the hospital. We've built time into this hour to allow questions because it's by sharing experiences, leader to leader, that we are able to keep ourselves and our patients safe. Before we hear from our nurse leaders, I'd like to share the results of an extensive survey of nurses and leaders. Then, immediately following, Linda Groh will highlight how AORN is responding to the crisis. This includes tools for nurses, leaders, and associations across the industry. Our two perioperative leaders will follow Linda to share their knowledge, successes, and insights from their experiences with the COVID-19 challenges. We'll then turn to the chat box and answer your questions as time allows. We do have polling questions at the end that will help guide AORN in what additional support and resources we can provide for you. Then we will conclude by covering the resources AORN has to help you connect with nurses and decision makers during this crisis. So a little bit of our communication with members. We sent out a survey almost 3 weeks ago and got over 1,200 perioperative nurses and leaders who responded and shared with us what activities and concerns you've had with this impact of COVID-19 in your environments. We've had clinical town halls that have been very well attended, over 1,000 people on the last 3 weeks. And then the YouTube of those virtual clinical town halls has also been viewed more than 2,500 times. We've had questions that all of you have sent us via the town halls, clinical consult lines, and OR NurseLink. We are listening to you and the needs that you have for answers and resources. In the survey, at that time, 85% of you told us that elective surgeries have been canceled. It's probably even more than that now. And that 75% of the managers indicated they're likely to reallocate staff between departments. You'll hear more today about how and where periop staff are being used. The top COVID-related activities were screening and restrictions, whether it was visitors, staff, or patients. Of course, converting and designating areas for COVID-19, alternate ICUs in some cases, or isolation areas. Of course, cancellations of elective surgeries was a big part of our world. Supply conservation, and then preparing for education and cross-training. The top requests from OR leaders and the ways that AORN could help were how to manage supplies during a pandemic, how to do the environmental cleaning with this new virus, how to keep yourself and loved ones safe, the personal side, how to receive and triage patients, and how to convert ORs and PACUs into ICUs for that critical capacity that all of us wanted. And then some of the open-ended comments, the key themes were very consistent. COVID-19 topics, there was so much, and still is, so much that's unknown. How to manage supply and equipment, or using it in new ways as we got shortages. PPE, what to use, when, what was normal, what's crisis. Leadership topics, supporting your teams, planning ahead. And ventilation, whether it was negative pressure rooms or the potential for surgical patients or medical patients in our areas. As well, 2/3 of the respondents said they weren't sure of what their hospital response plan was, or even if there is one. We heard you and your concerns. And now I'd like to welcome Linda Groa, AORN Executive Director and CEO, who will share more on AORN's response to the pandemic. Linda?
Good evening, everyone, and welcome to this Leader to Leader town hall. I'm going to be talking today about, first of all, the current status. This slide really speaks to the surgery response to COVID-19. The first phase we refer to as managing through this COVID-19 crisis. And for the OR, it was really a lot of resource intensive, answering questions, being supportive to the members, starting the town halls, we're in the toolkit for COVID-19. Critical Care Nursing Association developed an online education training program for refresher for caring for ventilated patients. So we had over 300 AORN members that took the opportunity to take that course. The organizations that were very influential and making decisions about what was going on in COVID-19, the FDA, for instance, and CDC contacted us about what our thoughts were and what our advice was on re-sterilization of the N95. Joint Commission contacted us and wanted to talk about what was really critical. That was prior to them deciding to cancel their reviews until June 1st. After June 1st, we will be talking with them to again work through what are the critical elements that they could be surveying for, and what are the ones that may not yet be back up to this meeting the standard. But the clinical town halls and the leadership town hall, as Renee just mentioned, were really very large, were very popular, very large, over 1,600 attendance at the very first one. We're now getting ready to move into the next area. And before we do that, this slide just demonstrates the member feedback. We've had excellent feedback from our members, a lot of feeling that we are supporting them, that it's an honor to be in this fight with you. And we are together in this. We are all together in this. And that's an important part of what tonight is all about. Listening and learning from you. There's a big question though. How will we know when it's time to reopen the nation, to reopen our surgeries? Dr. Gottlieb and others prepared a document that the White House as well as FEMA are using as guideposts. First of all, sustained reduction in cases in the city or the state for at least 14 days. Next, hospitals must be able to safely treat all patients that require hospitalization without resorting to crisis standards of care. And the crisis standards of care is what we are observing happening in many hospitals across this country, in the emergency rooms, in the hospitals that are being set up in convention centers and other areas. A state needs to be able to at least test everyone who has symptoms. And we know that testing is not readily available for all people who want to be tested right now. And then the state must be able to conduct monitoring of the confirmed cases and contacts. These were the criteria, these four, that were taken forward 2 weeks ago when AORN convened a organization, task force of the organizations of the American College of Surgeons, the American Anesthesia Association, and the American Hospital Association. We came together to talk about how can we create a pathway forward to resume surgery. What are the areas that we need to provide guidelines or policies for so that there is some semblance of continuity, consistency, and order as we go back to doing surgery? We all know that there's a pent-up demand for surgery. And unless we are going about this in a very organized, well-planned effort, we will see chaos reigning in our operating rooms. Most important, of course, is the environment ready? Is the operating room ready? Has it been converted from an ICU back to an OR? What about the ventilation? And all of the cleaning that needs to be done in those operating rooms before we even think about beginning to get them ready for surgery. Supply availability, managing the supply, and it's not just the PPD kind of equipment, it's all supplies that there's going to be a potential shortage. We know that there may be a shortage of drugs from the anesthesia perspective. What about all the available disposable drapes? So there's a lot of questions about equipment. We know that N95s are in short supply in many areas. Staffing, how do we bring the staff back into work? Some have been furloughed. Some are working in other areas of the hospital and have been retrained. Will they be ready to come back to surgery? And are we going to look at 5 days, 6 days, or even 7 days? And how do we staff operating rooms as well as the rest of the hospital if we're going to increase the caseload? Surgery scheduling. How are the schedules going to be managed so that there is some order and some guidelines available as to how we determine what is the most important surgeries that should come first? Are they the transplant patients? Are they the cancer patients? There are some models that are out there that are being worked on to help these kinds of decisions. And then, of course, regulatory issues. Almost all of the patients that were canceled immediately, the first ones, had their history and physical and lab work all done. Do those need to be repeated, or are we going to accept them? And how are we going to really test patients? Does every patient that comes into surgery need to have a negative COVID-19 test? And what about the staff, and how frequently? These are just some of the questions that this group is really looking at. We're forming some guidelines that can be used in your hospitals as this whole second phase of the COVID-19 is coming to the forefront. Now I'll turn it over to Carla.
Thank you, Linda. I will introduce and welcome the first of our speakers. Carla Brannon is Assistant Administrator, Perioperative Services, University of Washington Medical Center at Montlake Campus. This is an academic medical center that delivers quaternary care to a 5-state region and is distinguished as a magnet hospital. In fact, is the grandmama of all magnet hospitals, I understand. As you'll recall, Seattle, Washington was the first to confirm a COVID-19 patient and the first to experience a surge in cases. Carla, you were certainly navigating without a script in those early days. Tell us about your experiences.
Good evening, everybody. Yes, my name is Carla Brannon. I'm the Assistant Administrator for Perioperative Services at the University of Washington Medical Center in Seattle, Washington. And we have 32 operating rooms here on this specific campus. The perioperative department covers the operating room, the PACU, the pre-anesthesia clinic, CSPD. We have a business implant department, and then also the anesthesia support staff. We usually average around 35 to 70 cases a day before COVID. And we had the very first case in Washington on January the 21st in 2020. We started canceling cases around March the 16th, with our average volumes now being 20 to 30 cases per day. But we're also using the tier process, and we're only doing tier 3 cases. I can tell you that we started this journey very early in that we were watching what was going on over in Wuhan, China, and looking at what was going on. And then as we started seeing everything, we noticed that we started hearing that a lot of our masks that we have for the public were being used at a greater number. We were going through our stock. Then as we started going through this, we noticed that our PPE, especially our masks, were starting to be used a lot also in the operating room, and we were having to increase our stock. And it had gotten to the point that we felt that we needed to step back, and we actually ended up putting them in a room and locking them up. And then we started noticing more things were starting to come around. We had heard through some of our materials management staff that many of the stocks and supply that we had, actually originated in some of the factories in China in that Providence. So we started to see that we had more outages and that we were having to take a look at what we could improvise. For instance, our disposable bipolar cords were all of a sudden not available. So we had to go in and quickly buy some reusable ones and try and figure out how not to have people throw them away since they were used to being used disposable. And we also started taking a look at other things that were coming down the way. And we ended up, having our PPE, like I said, in a room locked, but then we had somebody that would go through and inventory it, and that would also then start to go through and dole it out as needed and ask the questions, why are you needing this? As we started to get into this first phase, we also had to step back and ask, who is coming into our ORs, and do they really need to be there? Being an academic center, of course, we're always having students come in, we're having observers come in, visiting physicians come in. And we really needed to make that decision with our medical leadership as to what we should do about having people not be there in the room if they did not have anything to do with the actual case of the patient. So we did eventually start to move that way because we were starting to run out of our masks. We did run out of masks with the face shields, and we ended up moving to goggles. We had somebody that donated goggles to the hospitals, and then we had to figure out how do we clean these goggles. So our CSPD actually took on that process and learned from our infection control department how we should be doing this. We also started looking at the process for decontaminating our PAPR shrouds. and the hoods that were used throughout the hospital, because we were going through them and we just didn't have enough. And then on many of those nights when we were sitting around and going, what do? We don't know what is ahead of us. We see everything else that's going on. We see that we have all these shortages. How are we going to keep ourselves safe? How are we going to keep our staff safe? So I ended up actually going to Home Depot one afternoon and just going through and finding things that could we use here in our operating room, looking at goggles that, you could use, looking at bunny suits, looking at different types of welding masks, something that would protect our staff and our physicians. As we got a little bit further into this, it really became apparent that communication was going to be a key. It's just so critical to have that consistent message and that specific place to go for the staff. We had to keep the surgeons and our fellow anesthesiologists informed as to what was going on. They don't hear what's going on with our huddles as to what kind of supply issues that we have. And so we needed to put messages out almost on a daily basis going through our list saying, we need you to know that we are coming up short on these items, and is there something else you can use? Do we need to get something in, or are you going to need to cancel the surgery? And so we had, at that point, trying to keep the physicians up to date with everything, and the beginning was a challenge. I think it's because, people were still like, is this really happening? And then finally it got to the point, especially when we had our first death in February the 29th, that this reality came to us. We also started looking at all the communication that started coming out. Our CNO started sending daily emails trying to keep us up with how many patients we have in the house, what kind of policies and procedures are new out there, things, that are going well to try and keep us looking at the bright side of things. As we got more and more protocols and guidelines, we noticed in the operating room that it was really hard for our staff to really find these things. So what we ended up doing was we have a surgical services intranet page for our department, and we went through and created a COVID-19 area that people could easily get to, and then we took policies and procedures that had to do just with OR, PACU, CSPD, and we put them in that area so it was easy for them to get to. It was not uncommon to spend an hour, hour and a half sometimes looking for that one policy that you just saw, but knowing how fast everything changed through this, that it would be gone the next day. So keeping up with that was really important. Then as we were starting to get all of these emails from all the different areas, we really, it was really hard to keep up with. And what should you look at? What should you not? Did you get it? Are you on the right list? So I went to the staff and I asked them in staff meetings, what is it that you want from me to help you with this communication? And so what we came back with is if I saw anything specific that I felt that they needed to know and they needed to pay attention to, I would resend out to them and put in the header as read so that they knew that that was the key indicator that you need to really take a look at this. As we went through our processes for the last couple of weeks, we have been very fortunate with our testing that now we are testing patients 72 hours prior to the day of surgery. If they do not have that test, if it is not complete, we do not do the case. We wait. If it is an urgent, emergent case, then we will take a look at, does this really need to go? And we have rooms set aside already ready to go for our airborne precautions. And we can always go in that room. We have 3 rooms specifically for that right now. At this time, we are past our quote-unquote peak surge. However, we are in a plateau. We are maintaining our steady numbers, but we're just really not sure where we're going to go right now as we especially move forward to a lot of the social distancing that's going to be lifted. We will be looking to see if we get any peak surges. Our governor did put a mandate out that there would be no elective cases until after May the 18th. We are looking to see if anything is going to be changed with that. So right now we are just maintaining, doing our tier 3 cases, which are our emergency, transplants, cardiac cases that need to happen based on that criteria. For the team, you know, we really got kind of scared all of a sudden because we didn't have as many OR cases. And so, you know, what were we to do? So we actually started looking at having our staff be trained for deployment for other things. I would say that it's really important to really have these conversations early and talk to them about change management and to give them the back that they need, that they can do this, that this is uncomfortable, we're going to make it through that, and we're going to make sure that you are comfortable when the time comes. We provided a lot of donning and doffing training, and that so they could go to the ICUs and the EDs to be able to help. They actually are having some nurses go through another training so that they can be nurse extenders and go to the ICUs and the ORs, the floors, so that they can be tagged with a nurse to help them. We're also looking at the opportunities, what can we do within our own department so that other people can be freed up in the hospital. For instance, we're looking at the terminal cleaning that EVS does, but we can do due to our volumes being down. So we reshifted and we are in the process of training and getting those things done so that EVS can go to other areas. We also took a look at what CSP could do to help with this. So as we got through looking at processing the shrouds, reprocessing the goggles, and now the N95s, we've been able to delegate that out to some of our staff so that they can be a part of that process. Through this, I have to say that it's been a wild ride, and you know, team care and self-care is so important. At the beginning, you know, you just didn't see it coming, and you just didn't know what was going to happen, and the fear was just so high. And so I think it's just really important that everybody says that, you know, we're one day closer to this being over. It's also important to, you know, give the staff the right information so that they can then sit there and say, okay, where are we in this? Because that will help to decrease all the fear and the anxiety that they have. It's very important to eat right. I can't say that enough, that it's so easy to go over to the peanut M&Ms and demolish that Costco bowl that we have that's being replenished on a weekly balance for the staff. But you really need to think very carefully about doing the right thing for yourself, making sure that you're eating right and you're doing all the right things with exercise. If people want to help, say yes. Let them help. You cannot do this by yourself. It is extremely difficult with everything going on, with everything coming after you at every side, that you just need the help. So, you know, take advantage of that, you know, and have people, you know, get into looking at being what we were calling COVID crusaders, you know, taking on, you know, the donning and doffing and watching everybody in the ORs, helping everybody else that's coming through the procedure areas. And then, you know, find time for yourself. You know, those naps are really important when you make it home. And then trying to at least one day a week, you know, turn yourself off from it and let your mind rest, because it will continuously go and go and go. And it's just really important for your own personal health and your mental well-being.
Carla, thank you. That was really helpful with some great information and reminders. We're also really glad to hear that the early signs of the surge being stabilized, and we hope that continues. I do understand that the mobile hospital at CenturyLink Field is getting packed up because it wasn't needed, which is awesome. And so it's available to send on to other areas of need across the country.
Yes, Emma, that was very good news for us. And we were able also to free up some ventilators that were appropriated to the state to go back. I believe they went to New York and some areas on the East Coast to help out.
That's awesome. I also want to remind folks that we are taking questions. There's the Q&A at the bottom. You can send in questions. We will have time live with these leaders at the end of this, and would love to have more of your questions. I see some coming in, and we'd love to see more. So next, I'd like to also welcome Debbie Ebert. Debbie is Vice President, Perioperative Services Memorial Care Health System in the greater Los Angeles area, or another hotspot in the country. I know that one of the Navy ships has recently arrived in your area down there for some extra capacity. Debbie, thank you for joining us. Please tell us about some of your experiences on this journey.
Oh, absolutely. Thank you so much. And good afternoon and good evening to my colleagues that are in the Midwest and on the East Coast. First, I want to thank AORN for providing this time for us to share our experiences as we navigate through this crisis. And Carla, I also want to say thank you to you. Seattle domestically took the first blow. And as I go through a little bit about our administrative response, we were watching and communicating with your medical community and nursing community there. So we use that a lot in our decision-making process. So thank you for that. And I'm glad to hear that things are leveling off for you. Again, I'm with Memorial Care Health System in the greater Los Angeles area. And we are a clinically integrated health system. We have 4 magnet hospitals, 2 located in Los Angeles counties, and 2 in Orange County, California. So as Renee indicated, we have had quite a challenge in our area following Seattle. For our hospital, we've actually done pretty well. We have 62 ORs within our health system. We were doing around 225 cases a day. We're now doing about 10% of that. We also stopped doing our totally elective cases back on March 16th. As you can imagine, that created quite a stir, as it did everywhere, cutting off our department at the knees. So I think one of the reasons that we have not run out of supplies, even though we're midway through our surge, has really been our administrative response from our organization. And I'm going to share a little bit of that with you tonight. We always like to formulate guiding principles to lead us in our decision-making process. So I'm going to talk a little bit about the corporate response, as well as how we've supported our campuses and teams through this. So our number 1 principle, and we had about 10, was our top priorities: protecting staff and physicians, because if we're not healthy, as Carla pointed out, and taking care of ourselves and providing that self-care, we're not going to be here to care for our community. So that was our guiding principle. One of the others, I think, is you're navigating through these times where it's challenging, we're collaborating, we're in unknown territory, we're crowdsourcing, and as we're having these conversations and breaking down silos and providing opinions, is we always want to assume good intent. That's a huge part of communication and being able to collaborate. So again, our aim was for employee and physician safety, top priority. We wanted to create the safest environment possible for our employees, physicians, and allowing our employees and physicians to be safe, feel safe, and hopefully still experience some of the joy that we find in caring for our patients as caregivers. So we actually started our response. Our senior leaders started meeting at the Corporate Command Center back in mid-February. We set up our incident commands in early March, and our governing principles, as we just stated. And we started having twice a day conference calls, setting up what our data was going to look like, and dashboards. And again, really following what was happening in Seattle so we could look at what we needed to model and anticipating our surge. Next slide, please. So a little bit of the work streams that we set up, and I think this is so important in our response. As Linda alluded to earlier, I was surprised to know that so many of our colleagues and their organizations did not even realize what their disaster response or disaster management was, or if they even had a workable plan. So these are just listed on the screen for you. Some of our key work streams, most of what you would expect to find there. I think one of the plans that I wanted to talk about was the TLC, that's our tender loving care. And again, that goes back to, as Carla mentioned, that importance of leadership, taking care of our teams, particularly with the anxiety around the unknown that we were facing and the fluidity of the situation that we're trying to lead in. So next slide, please. So again, on the campus level, our chief operating officers are set up as the incident commanders. And then some of the key members are the leadership that you would find there, as well as the department leaders. And they met, again, quite early. There was good communication between our shared services or corporate office to support our campuses, because that was huge for them as well. Next slide, please. So moving down into teams, and I know Carla, I think, alluded to most of this already. I think a lot of us were following into first steps as we began to understand what we were dealing with, and we had not stopped our elective procedures, was how were we going to screen? Because we knew that the danger was there. We were still learning. So we did, across our system, develop a standardized screening tool for our pre-op patients on the pre-admit calls, started screening our visitors. So that was really our first step. Next, again, surgery and procedural case scheduling. We developed a triage tool to provide guidance so that we had some standardization in what surgical procedures would go forward. And we sent out a letter asking our physicians, if you have a patient that's scheduled and they can be postponed for 4 to 6 weeks without any negative outcomes, that's how we started with ours. So we did have a standardized tool. So again, back on 3/16, we did pull the trigger on that, and we are currently doing urgent and emergent. We have quite a large staff. One of our hospitals in Los Angeles is a level 2 trauma, and it is also a teaching facility. So we had some of the same concerns with our PPE, having to make the call on limiting who was entering our zones. We had to redeploy a lot of our staff, a lot of retraining, and we can talk a little bit about how we utilize those. As as we all know, we have talents and skills that perhaps some of our colleagues and some of the other nursing units don't possess. So we've been able to find some niche areas where we could really support our hospital and our other teams. And then really looking at peri-op operational changes. So what we had initially set out with our anesthesia partners to do was we established intubation teams, again, trying to minimize risk. We set up some of our operating rooms into negative pressure just for induction and extubation. And then we would transport them into the OR for their procedure, and we established a protocol for that. We also utilized the aerosol cubes that, again, would minimize some of the aerosolization with intubation and extubation. And we used PAPRs and CAPRs for our anesthesia and for our code teams. So we were very fortunate in that we were able to stick with that plan and have the supplies that we needed. Recovery. So we've really turned our focus now to our recovery process. We've actually started meeting and developed a work stream a couple of weeks ago to start to see what that's going to look like moving forward. So some of the considerations, and I'm sure these are some that all of us have as well, is suspension of block. If you are still working with block times in your facility, how is that going to impact extended days and hours? How are we going to prioritize our cases, depending upon, and for many of us, we have quite a backlog. Supply chain support. My VP for supply chain is in the office next to me as we speak. He's on the phone 24/7, has really been a champion for us. But I'm curious what supply chain disruptions lie ahead of us. and how we can partner with our industry partners more to have an understanding of what that's going to look like and how that might impact. Again, our staffing matrix, we touched a little bit on that, what that's going to look like, as Carla mentioned, with the changes. I question the future of anesthesia practice with COVID-19. How is that going to impact their processes? And then the partnership with our surgeons and schedulers, you know, how can we reach out to them and partner in what that process is going to look like? So advance, please. Thank you. So I wanted to share a little bit about what I've learned for leadership and crisis management. So for me, I think the number one is leading from the front. So the first few weeks that we started this journey, I was in my normal pinstripe suit. The last 3 weeks I have lived in my scrubs. I've partnered with one of our ER physicians who has been in Afghanistan and Iraq to create the hot zones and train people to work in the hot zones. And our other leaders have stepped up to do that. So I think that's probably the number one lesson that I've learned, is how important it is that the staff see us. So visibility, even if you're not in scrubs and you're not there as often, just being visible, rounding, taking that pulse check for how are you doing, reassuring them, as Carla mentioned, that they're going to be safe. Confidence. I think that leaders must exude confidence, even when maybe we don't feel it, to decompress that stress factor. I think, again, the uncertainty that our staff is feeling, and all of us are feeling, actually. And I know we've all touched on the importance of clear, transparent communication, and often. I don't think you can over-communicate, particularly in this situation. And we've worked a lot on that. I think Carla touched on it, the huddles, the daily updates going out from our marketing and PR. Just again, that daily email that we make sure that our teams are receiving with all the latest information, and that open door policy. And then I think compassion and assuring the teams. I don't think we can overemphasize those two and how important it is with everything that they're feeling, whether they've been furloughed or they're reassigned to an area, donning and doffing, or on turning teams into an arena that they're not usually comfortable in. Advance, please. Professional organization contribution. So I wanted to share a little bit with this group about what I've realized from my professional organization, my relationship, a little bit about my epiphany, and I'm going to embarrass myself. So I've been involved with AORN since 1978, when our local chapter awarded me the AORN award, and in my area, and which is great. So that was my journey. So here I am. You can do the math, years later, and it's been 40 years, and I don't think up until lately I truly realized how important that association has been. I've always valued it, but in the last 4 to 6 weeks, being able to pick up the phone, email, and share this experience and this uncertainty with my colleagues, and having AORN step up and provide the support that they have, I think has really been an epiphany for me. So I want to express gratitude. I think gratitude is the other thing that's really important for us to keep top of mind as we're navigating this. And I'm wondering a little bit about the vision for the future, Imagineering, if you will, for future state, as we ask ourselves, what impact is this going to have on our strategic plan? How are we going to support our organizational leaders as we navigate? And then again, my expression of gratitude to the AORN staff and the board, because they are leading all of us through a very challenging time. So again, sharing that gratitude. Thank you. So our major challenges, again, common theme, no surprise, supplies. storage for some of us when we do get our supplies. We've been on just-in-time industry standard for our supplies for so long. The other thing we've noticed is PPE knowledge base and skill set. That was pointed out to me by physicians, anesthesia, and even our team as we've retrained them. So I think there's a global challenge for that in all of our hospitals. Of course, goes without saying, disruption of our revenue system for those in leadership, and having frequent conversations with our CFOs. And then for me, the unrealized consequences on the future of our operations and our workflow and what that's going to look like. Next slide, please. So my key takeaways, I think that's been helpful in our particular journey is our early disaster management plan and implementation. I think that's been really helpful. I think it's helped us to stay in the supplies we've needed and to be able to reassure the staff as much as we have with their communication pathways. Our governing principles, that is our true north. The daily Periop CDC evidence review, and again, just the crowdsourcing with our colleagues has been very helpful for us through this journey. The daily tiered huddle communication system, strong supported teams, visible leadership at the front line. And then right now, 24/7 for me is that proactive recovery plan for when we will come out on the other side of this. Next slide. Okay, and I just want to thank everyone for their time and again for the opportunity to share this journey, and I wish everyone on the call and their families continued good health.
Thank you so much, Debbie. We're really grateful for your support of AORN over the years and in tonight's town hall. I know it's a really busy time and it's valuable information that you've shared. I wanted to, just before we go to questions, and we've got some really good ones coming in, we had spoken to one other leader from an academic medical center in the Northeast part of the country who isn't able to join us tonight. A couple of quick things from this leader was that they felt they were yet to see their peak surge of COVID-19 cases, which is a little bit different than what we've just heard here, because it's different in different parts of the country, as you well know. She reflected many of the same themes of managing PPE tightly and creating protocols to help drive consistent practices in a time of rapidly changing information. This site was preparing one of their PACUs to be an ICU to increase that capacity, and currently had 4 of their ORs converted to negative pressure for COVID positive patients. They're providing education for their perioperative staff to help in a variety of support roles throughout the organization, very similar to what we've just heard. This leader also stressed how important frequent communication is, a really strong theme, is for dealing with the amount of rapid change and the level of anxiety for staff, and how important leadership presence and visibility is to staff feeling supported. She also reflected on the larger sense of community that has arisen from working closely across department lines, and that she also has a concern about having adequate staff for whenever elective cases return. So let's go to some of these questions. I'm seeing a number of questions around, are you testing staff or are you having staff that are getting sick?
So this is Carla. I can answer from the Seattle side. We are not testing staff regularly right now. If they have symptoms or if they've been exposed, we certainly have a way for them to go online and fill out a catalyst in order to be put in the queue to be able to have that testing done. It's hard to say how many people that I don't know how many people we've had come down sick from patient exposure at this point. I know that we have had a couple people that have come out as COVID positive, but we're not really sure whether or not they were work related or just out in the community.
Great.
Great.
And this is Deb. I would add that we are not routinely, again, for exposures. I will comment, though, in our area, we really are very light on testing materials. So that is a challenge for us.
Absolutely part of the challenge. I'm seeing some other ones about what type of COVID positive patients are you seeing come to surgery? Carla, I think I remember you telling me one of the first
Yeah.
ones. Yeah.
So, you know, in the beginning, we really didn't think, oh, we're not going to see that many COVID patients come through. And very early on, we had a patient that was trached in the ED who was bleeding, and we had to rush them over into the OR to help control the bleeding and take care of them. We have also seen pending patients with appendectomies early on before we had more rapid testing. C-sections, people who either were pending COVID, or either they have actually started doing the COVID positive pending patients in the L&D, and so we're having to hold a room in the OR for the other crash case that might come down that's not COVID positive. And then, you know, there's a lot of questions around the bronchs that we have going on right now with bronchoscopies.
Deb, did you have any other things that you were doing with OB? That's another question that I'm seeing pop up, is what about the OB population? It sounds like it's coming into the peri-op environment a little more.
Right, and that does fall under peri-op with us, and that's a great question, actually. We have seen it, our positive patients within that patient population. The other thing that we started doing early on is, particularly going into the later phases of labor, is having our nurses wear N95s, just because of all the aerosolization in the room. But we are seeing it in that population, and I think we've struggled a little bit more, honestly, too, with our family and visitation in that situation as well.
Great. One question about the tier 3 phrasing that, or organization that we are using to describe cases. Can you describe that so it's familiar to our listeners?
So for the tier 3, those are the cases that need to be done more urgently due to the patient's health or a treatment. So we've been doing a lot of our cancer cases. And then, let's see, the other ones we've been doing are the transplants, obviously. And anybody that might be losing function with something that would be permanent damage.
Great, thank you. What about anything else you want to add about supporting staff who are being stressed or morale? I think I've heard of places that have had a dance to some music in the afternoon or a joke in the morning. Either of you want to share any more about ways that you've helped support it during stress?
Sure, this is Deb. I can certainly start that. We do a tea for the soul that we have our pastoral services come around. We have a virtual appreciation wall on our intranet that we use. We have our teams that are rounding around the clock, really with snacks for the break room. We have a little bit of entertainment at one of our centers with one of our doctors who's a guitarist, which has really been nice that he's and shared that. So actually we've had quite a good response in that regard. And I think, again, to emphasize, I think that's very important for the morale.
Yeah.
So we've had the same things up here, but I got to say that we've also had a great response from our community, bringing in food, wanting to help in any way possible. It's been really touching as they've been coming in and supporting us.
That's awesome. Great example of wrapping around our front line. Another great couple of questions are around either one from a nursing student asking about, hey, how can I be part of this? How can I help a future employer? And someone else asking about training nurses new to the OR during this time. So that, with the decreased caseload and some of the uncertainties, are either of you starting to look at that?
So this is Deb. I'll start there. Give her my information. I'm always looking for talent, no matter what the climate is, just because we've learned from our recruitment and retention task force this year that we always need to be looking for training more nurses. How that will impact, we do have an active Periop 101 program. Of course, we did have to pause, but I don't think that's going to change. We will continue when at the appropriate time in our recovery plan, we will re-engage, if that helps.
Yes.
Yeah. This is Carla from Seattle. So many of our nursing students are going through the Department of Nursing here at the UW or with their universities to see what they could do, and then reaching out to various entities around the hospital to see where they could be used. I'm not sure, I know that we don't have anybody in the ORs at this time. We do have a perioperative consortium here, and it was put on hold, but we decided, even though it had started, that we would continue with it. And so they're doing a lot of our talks and education through Zoom, and then working through a little bit more, trying to go through with the cases, because we started during a fair amount of ortho cases and neuro cases and general cases and robotic cases because of the cancer and the other things that we're doing. So we are trying to continue on with that and keep them going.
It's great to hear. I have heard from other nurse leaders as well that how there are some early retirements. There are some folks who have said, you know, I'm tapping out. And so as we look at resuming the volumes, the amount of staffing is going to be another concern, and how quickly can we ramp up. So thank you so much. We have lots more questions. I will tell you that just as we have done with the clinical town halls, we will be looking at all of these questions and getting back to you if they're specific, or making sure that we're gathering those resources and putting them again towards our web pages with additional resources and answers for you. So thank you for sending those questions in. I want to say absolutely thank you to our guests today for sharing your experiences and your time with all of us. It's invaluable, and we really appreciate it. And now I'd like to take a minute to collect some feedback from you. We have a few polling questions that are pretty quick, but we want to get your answers to these as we prepare for how else other kinds of resources we can provide for you. So I'll take a moment here where you can look at these and answer for us, please. Thank you for giving us some of this information. It's really helpful for us. So before we close, I'd like to remind you of some of the many resources AORN has to support you and your team. AORN's COVID-19 on the AORN.org website is an extensive clinical resource that is updated daily. Please check it often. It includes answers to frequently asked questions and links to a toolkit that contains the latest recommendation from trusted resources such as the CDC, WHO, professional organizations, and regulatory agencies. And I will tell you, just in scanning some of the questions that have been sent in, there are answers to many of those on those pages. The FAQs cover a wide range of key clinical questions and guides to balancing the risks and benefits of various situations that the COVID-19 challenges are bringing us. Your questions and feedback today will help us bring the right leadership resources to this page as well. As we begin to move from crisis to recovery and a return to elective surgery, we will need your input and partnership in bringing our best thought leaders to this important work. On May 1st, AORN will launch a virtual expo The virtual expo is an opportunity to connect with each other and enjoy some of what we've come to value about our annual convention. With our virtual expo, AORN is recreating the live expo event for nurses. Education hubs, CEs, poster galleries, live and recorded events. At our online, we will also have an online expo store, the expo hall, and more available, along with activities and promotions to absolutely keep it fun and entertaining for nurses to connect with key exhibitors. The virtual expo is available free to all AORN members and will be online May 1st. We at AORN are really excited to be able to create this for you, and we hope that you will all take advantage of this. Finally, I want to acknowledge the brave leadership each of you represent in caring for our patients and our perioperative teams on the front lines. Thank you for all you do each day, and please take care of yourself as well. This town hall is concluded. Thank you so much.